dim the lights just ever so slightly, because some of these slides really won't show up. Thank you, Congressman McCall and Congressman Van Hollen and the distinguished members of this caucus. I came here last night, took the train down from Amtrak, and I knew a few very close friends, Evan's family among them, and Nancy. And I left here last night after that wonderful reception feeling like I made many more friends inspired by some incredible stories. So I'm grateful for this opportunity. But I represent a very large team of people who are trying to tackle very rare pediatric brain tumors using something called immunotherapy. And this is a little bit about our story. About 15 years ago, we were noticing that some of the children that had stage 4 neuroblastoma never had the disease come back in the body. The chemotherapy actually worked in the body, the radiation helped, but these tumors were coming back in the central nervous system, so the brain was really serving as a sanctuary site where some of these tumor cells could hide, so you could, in effect, win the battle on the body side, but then ultimately lose when the tumors came back in the brain where there were very few effective therapies. And if you note the incidence here, it's not just in the pediatric neuroblastoma population, but it's in many adult tumors as well, where the incidence is 10 to 20% overall for all of our patients having recurrent CNS metastases. So one way we could actually tackle that is by using radioimmunotherapy. So by this I mean an antibodies that were so well described by Dr. Nickel, targeting certain kind of proteins or certain kind of tumor markers that are on the surface of these tumor cells. And they can be given intravenously, they can be given directly into a tumor in the brain, they could be given into the cerebral spinal fluid. And one of the ways to make them even more potent is to add something called an isotope, which is really using the antibody as a means of delivering targeted radiation to a tumor cell. So this was our bold question: can we cure an incurable cancer in the brain? So the two agents I wanted to talk about was 3 of them targeting that tumor antigen GD2 linked to the isotope I-131, which was supported by the FDA Orphan Drug Grant program, and another antibody, 8H9, targeting the tumor antigen B7H3, also linked to I-131. This picture shows the antibody goes exactly where we want it to go. The black outlining the entire cerebral spinal fluid, and this is a picture taken 1 hour after injection and then showing clearance at 2 days after injection. But we were seeing that this treatment could be safely delivered in the outpatient setting. And this is where we're at to date. Over the last 10 years or so, 138 patients with about 550 injections. The primary central nervous system tumors, very rare tumors, ependymoma, medulloblastoma, choroid plexus carcinoma, chordoma, atypical teratoid rhabdoid tumor, and embryonal tumor with abundant rosettes. And then tumors metastatic to the central nervous system, melanoma, Rhabdomyosarcoma, sarcoma, retinoblastoma, and neuroblastoma. But the encouraging thing for us was to see that for some children, you can actually eradicate these cells that are hiding out in the cerebral spinal fluid. So historically, children that had the neuroblastoma come back in the brain all died usually within a few months from the time we ever detected the disease. When we started adding the adjuvant therapy with the antibody after all of these children went through chemotherapy, radiation, surgery, well, many of the children looked like they never had the tumor come back. So since this time, it's been about 55 children with this type of neuroblastoma have been treated with the same way. And it's encouraging that there's an improvement in the survival. But as you can see, the line isn't straight across at 100%. There's still so much work to be done. This scan here, I think I would have quit when we first detected the disease in this child. There were literally hundreds of tumors that were in the brain and the spinal cord. Next one, Andy. And you could even see that they were penetrating through the back of the retina. Next slide. And on exam under anesthesia, all of those white small markers representing the neuroblastoma tumors that were hiding out in the retina. Nonetheless, we went through the entire treatment, and it's been almost 4 years, and we have clean MRIs and a child that actually has normal vision. So, in reference to Dr. McCall's wonderful statement about this being an international problem, this little child that had the hundreds of tumors is not from America. Family raised all the resources to move and spend all this time and get this treatment. And she's been back home in Europe for years, but on the 4th of July, her father sends me a picture of her and says, really, she was reborn in the United States, and Lily is a very proud American. Okay, now just moving on to probably one of the most challenging cancers we have across the board, something called diffuse intrinsic pontine gliomas, DIPG. This is a tumor that sits in the brainstem being really the hub of all our neurologic function. And there's approximately 200 children per year in the US that are diagnosed with this terrible tumor. They're all young children between the ages of 5 and 9. Represents about 10 to 15% of all of our tumors, but it's inoperable. Radiation therapy is the standard of care. It helps for a few months, but it's a uniformly fatal type of a tumor with over 90% of children dying within 12 to 14 months. But the big red flag is here, no advances in 40 years, not one drug that has changed that statistic of every child dying within a year or a year and a half. So could we test the antibody directly into the brain stem? So this is a team approach here. Our very brave, sorry, back it up, Andy, sorry, I went too fast. Neurosurgeon Mark Sweden puts a catheter into the brain stem in the operating room, and by something called CED, convection enhanced delivery, gives this antibody delivered into the brain stem over 6 to 8 hours. And then the children recover in the intensive care unit overnight. But if you look at the PET scan, 1 to 2 weeks afterwards, the treatment is going right where we want it. That's that hot spot showing that the antibody is binding directly to the tumor and sticking there for 1 to 2 weeks after the infusion. So far, it looks like the CED with the 124-8H9 for patients with DIPG is safe. It's certainly delivering a dose of radiation, but this is the goal that we have to achieve, to safely deliver enough targeted radiation by CED to improve the survival for children with DIPG. We have tried to reach as many children as possible from many different cities across the country and from many different countries throughout the world, but next slide. These are our limitations here, the biggest of which is drug availability. As a single institution, we have never studied these drugs on multi-center consortium trials, mostly because it's drug availability. The cost of producing a clinical grade drug and the cost of the data safety and monitoring that goes on with consortium trials is really prohibitive. But I think we're at the point where some of these barriers could be overcome. There is a new form of the antibody, HU3F8. It's really a humanized form of the antibody, and in every preclinical model, this works infinitely better than even our old form of 3F8. The HU3F8 was actually made and produced and supported entirely by a group of parents who got together, the band of parents, and supported the production of this antibody. It is now in 3 different active trials, as a single agent, with another immune modulator, and with the radioisotope tag. And it has recently been given FDA designation, orphan drug status for children with neuroblastoma. But even more exciting is that the FDA designation orphan for this drug for children with osteosarcoma is in place, and a multi-center randomized trial, which would be the first for children with osteosarcoma, is underway. The other exciting thing is that the HU3F8 really seems to target other GD2 expressing tumor types, including stem cells and other malignancies. So I think the promise of this being an adjuvant therapy for some of these rare diseases is really enormous. But all of this is the basis for having a successful Creating Hope Act. That is a win-win situation. We have access, everybody would have access to a drug that could really change that survival curve, and obviously the pharmaceutical voucher incentive is in place for a win on the other side. Next. Why am I so convinced that things are going to change and that those survival curves for these rare orphan diseases are really going to be something of the past? I think just naming the commitment that all the members in different departments at my institution, there's commitment at the national level with leadership at the helm of these organizations, the likes of which we've never had before, the Children's Oncology Group, the Pediatric Brain Tumor Consortium, the new approaches to neuroblastoma therapy, and other major pediatric cancer hospitals that are joining together as part of a consortium. Then there's the commitment at our parents and family level. This is just a list of the organizations that I have had contact with, not even my extended colleagues. And you know, the support comes in so many ways. Yes, philanthropy is one, but advocacy and awareness are raising, sometimes emotional support for other newly diagnosed families, and emotional support for our team all come into play. This support is sometimes from the parents of children who have lost their child decades ago, but stay intimately linked with where we're at for their cause today. And sometimes the support is from families of a child that I never even had the honor to meet. And of course, commitment at the highest levels of our government is so critical, and that includes the FDA Orphan Drug Program, the National Institutes of Health, Congressman Michael McCall and his lovely wife Linda, Congressman Chris Von Hollen, and all of the members of this caucus. The Creating Hope Act will be one of the most successful things that I really believe will change the natural history for these diseases. Now I'm going to give one personal twist here. I am a 5th generation New Yorker, proudly born and raised, all of us, in the Bronx, New York. And of course, New York has its challenges. You know, some of them we never saw coming, and others, on a much lighter note, are welcome with open arms. Like, will the other New York baseball team ever win another World Series championship? But, next slide. In keeping with this, you know, every few years we try to have a gathering for our patients that are on treatment, patients that are off treatment, and it's a time for us to be together and celebrate being there outside of the hospital setting. It's also a time to remember many of the children that we have lost and to remind us why we have to keep moving forward. But in keeping with this baseball theme, we had something called the Field of Dreams, and every child listed what their dream is for our country, for themselves, for their families. We had many members of the 1969 World Series Mets came in and reminded us that these kids are the real heroes. And we were even graced with the presence of Mrs. Jackie Robinson, who is probably this country's greatest living example of hope for a better tomorrow. So with that, I'm going to close with a statement that we had